Today we are discussing a case about organophosphate poisoning. We have our VV sir with us. Can we start the case?
Okay. Thanks, sir. Good morning. Sir, a 37-year-old female was brought to ER in an unresponsive state. In my initial 10-second assessment, patient is very drowsy and with very low GCS, but central plus pulse were present. And I got a brief history that it is alleged history of some poisoning. So an emergency decontamination of all the dress along with the immediate wash of the face and the upper limbs and the central chest area was done. And following that, I went into the primary survey. In primary survey, airway is having a lot of secretions.
For that, can we tell about that need of keeping the clothes for further forensic?
For this patient, we have immediately kept all the dresses in a plastic bag, in an airtight bag. For any further forensic use, we will have to preserve the clothes, sir. While doing decontamination, one more thing is that we are supposed to use, in case of Organophosphorus poisoning and all, it is better to use a rubber gloves rather than a latex gloves, because it has some amount of solubility into if you are using a latex gloves.
Can we register it as an MLC, sir? Medical legal case, organophosphate poisoning.
In this case, did you register it as
so no, sir. Ideally, we will have to preserve everything. In case this patient expires, then we will have to proceed with an MLC, sir.
That is the protocol that is followed.
Yes, sir.
Is attempted suicide punishable?
No, sir. Right now, it's not happened.
So it is not essential.
Yes, sir.
Unless
Patient
death occurs or condition deteriorates. In which case, it's always better to make it MLC.
Yes, sir.
And notify the police also.
Okay, sir. So now I am going ahead with the primary survey. In primary survey, first it is the airway, and for this patient, airway was having the oral airway was having lot of secretions, and some amount of vomitus was also there. So in order to secure the airway, immediately I go ahead with rapid sequence intubation. And for rapid sequence intubation, I selected the drugs like fentanyl 0.1 microgram per kg and ethambutol 0.3 mg per kg. And for muscle relaxation, I used rocuronium at a higher dose of 1.2 mg per kg. And I secured the airway with a 7.5 size ET tube. Then after securing the airway, I went into the breathing part, sir. And breathing part, air entry was bilaterally equal, but there was bilateral Krebs as well as V's present. Now, initially she was having a respiratory rate of only 15 to 16, but now I have put her on mechanical ventilation. Now I have kept the respiratory rate as 22 and PCV mode, right, sir. Then coming to then in breathing part itself, now she is attaining a saturation of a 91% in the 100% FI on the ventilator, sir. But her initial arrival saturation was only 80. Only post intubation her saturation has improved. Then coming to the circulation part, she is.
You want to keep a higher PEEP if the saturation does not increases here.
Sir, for recruitment maneuver, we may increase the PEEP.
So because there are a lot of secretion, something like ARDS.
ARDS, sir.
So ARDS ventilation as such may not practically yet, but we'll have to go to a level of ARDS ventilation.
So initially she was achieving adequate tidal volume, so I kept the PEEP, and I was observing her, but she gradually actually increased the saturation.
Okay.
For and circulation part, her peripheries were cold and there was profuse sweating, and BP was high, only systolic BP was recordable at 80, and heart rate was she was having tachycardia of 122 here.
Is there anything which can reduce saturation other than secretions in OP poisoning?
In secretions, respiratory central cause, it can cause respiratory depression.
More than that, the muscles of the
muscle paralysis will be also there.
That is a very common finding in many patients.
Muscle paralysis.
That also we have to keep in mind. Some patients may not have so much secretion, but muscle weakness itself can produce this problem.
Okay. Then following with right now, already I have secured her on 2 IV cannula. Now I immediately checked the IVC also. IVC was only 0.8 centimeter and it was completely collapsed. So immediately I bolused 1 liter of IV crystalloids, and then I went to the disability part, sir. In disability part, her GCS, initial GCS was E2 V2 M5, and in view of low GCS and oral airway not patency, we have intubated the patient. Now post intubation, her GCS was E1 VT M1, and pupils were actually 0.5 mm bilaterally constricted, and it was not reacting to the light, sir. Initially also it was like that. So that's the disability, and GRBS was also checked at that time.
Can you tell the toxidromes of constricted people? Correct, no, sir?
Yeah.
Toxidromes.
Sir, one is opioid poisoning, then morphine poisoning is there, and any cholinergic drugs can cause meiosis. Other than toxidromes, in brainstem infarct or bleed, pontine infarct or bleed, we can have pinpoint people, sir. Or post cataract surgery, same thing, and we will have a non-responsive people, sir. So that's the disability part. GRBS was immediately checked. It was 112 milligrams per deciliter. And in exposure part, we have already did the decontamination on arrival itself. And in other than the exposure, peripheries were cold and was profuse sweating. So immediately we gave.
Decontamination, what exactly did you do?
Actually, in decontamination, we will have to. This is a suspected case of poisoning from the brief history that we initially got. So immediately before arriving to taking to a resuscitation room, patient was actually taken to the decontamination room, and we removed all the clothes, and we kept the all the clothes material in a plastic bag, in an airtight bag. Along with that, we actually gave some saline gauze, and we immediately cleansed the patient's visible areas, sir. That was the initial decontamination done for this patient, sir.
Subsequently, did you do anything else?
Actually, this patient already has received activated charcoal, everything from the referring hospital. So patient, she was already having
was stomach wash done?
From the referral letter, I think they have already put only a Riles tube and got some gastric aspirate. They have not clearly mentioned the stomach wash was done. From the RT, they have taken the samples and given. They have brought, bystanders brought it along with that. But they have given activated charcoal, but dose is not mentioned, sir. And atropine also was given, but dose is
Suppose it had come here first, what would you have done?
One is if the patient is already brought in the initial 2 to 3 hours, then we can go ahead with stomach wash.
Up to 3 hours?
Initial 2 to 3, because gastric emptying occurs within 3 to 4 hours, and also the organophosphate has rapid absorption. So usually if from the mucosa and the GI tract, the absorption rate is pretty very high, sir.
What is the WHO recommendation for stomach wash? Up to what time?
Sir, up to for 3.5 to 4 hours you can give stomach wash.
Actually, it's just 1 hour.
WHO recommends it is 1 hour. Many rural practitioners still do it because they may not have. Some doctors still practice that. WHO says it is 1 hour. That is the guideline.
Okay, sir.
Activated charcoal, how much would you have given?
Actually, the dose is 1 gram per kg, but this patient dose they have not mentioned. But ideally, we can give 8th hourly 50 gram activated charcoal. Still, the patient symptoms improves or patient started passing activated charcoal. For this patient, and so now then I reassessed the entire primary survey. Now her airway is patent, breathing has saturation is gradually improving, and the circulation part, her BP has now improved to 112 systolic BP with the 8 diastolic BP, but MAP more than 65. Then disability, here GCC is still low.
What is the pulse rate of this patient?
This patient when I brought with a tachycardia of 122, sir.
Can you tell the reasons for tachycardia in a patient?
Sir, one is in suspected in OP poisoning.
OP poisoning.
In OP poisoning, maybe an early sympathetic response the patient can have into tachycardia, but progressively the patient should go into bradycardia in case of overdose.
But around 20% will have persistent tachycardia.
And
that is a problem in OP poisoning. Some patients you can see they'll have only tachycardia, but all standard books use it is only bradycardia. But some patients will have tachycardia, 20%, around 20% because of nicotinic activity they can have.
And one more thing is that this patient was already received an unknown dose of atropine, maybe because of that, but it's not proper atropinized so far my examination.
Atropine only problem is when you tell atropinized tachycardia means atropine acts for very few minutes. The action on heart is only short acting.
Yes, sir.
People will be long acting. So if you are given atropine, then tachycardia may be due to atropinization. If somebody else from outside has given after 1 hour, 2 hours, it may not persist. That is the only thing you have to.
And one more, the patient is having hypotension, maybe because of
that may be the reason.
So that was a primary survey, and as adjunct to primary survey, I asked for an emergency ABG, and asked for, since there is secretion emergency X-ray chest, and since because of tachycardia, I asked for an ECG, sir. These were the 3 things that I asked as a adjunct to primary survey, and the ECG actually was showing only sinus tachycardia, and X-ray was showing only raised bronchosvascular markings, and the ABG was showing a metabolic acidosis, it's a pH of around 7.25. PCO2 was slightly low, it was 30, and bicarb was low is 16 only, but lactate was elevated 8 to 9.
Mostly because of hypotension, she might
Hypotension.
have developed lactic acidosis.
What are the other features that you can expect on ECG in
Sir,
OP
in
poisoning?
ECG in OP poisoning, one is tachycardia, then QTC prolongation, pre-R prolongation, and VF, VT, ventricular tachycardia, ventricular fibrillation can be there. Sir, and variant degree of heart block is also possible. Okay, sir. Then I went to the ample history. No history of any allergies, no history of any past medical history, then no relevant past history. Then even lead to the patient arrival is that patient was found unresponsive today morning in her room, and following which she was actually vomited. Some vomitus was present near her, and along with the involuntary urination and defecation was also there, and some amount of a bottle was there. It was an insecticide. From the referral letter it is mentioned chlorpyrifos. Then this it unknown quantity, but already half bottle remaining was there. No other bottles were visible, and she was found in an unresponsive state, following which they have taken her to a local hospital, where they have put the Riles tube, and from the history they are given a stomach wash, and from the referral letter I understand they have already given atropine, and they have taken the samples, and they have already given activated charcoal, but doses
Can
not
you tell
mentioned.
the analytical part of this samples? How do we send samples for this patient?
What would you like to collect immediately when such a case comes?
Sir,
What kind of analysis is very important?
Actually, we have to get the initial gastric contents is important, and another thing is blood level we can take, because we can check the pseudocholinesterase or RBC cholinesterase level.
Which kind of tube is used for cholinesterase estimation?
Sir, I think it's plain. I'm not sure, sir.
EDTA, preferably.
Okay.
Both for
Well,
erythrocyte as well as pseudocholinesterase. We do pseudocholinesterase only here because that is enough for acute poisoning. For chronic poisoning or recurrent exposure, erythrocyte cholinesterase is recommended. Is it important for you to find out what kind of OP compound is involved?
Yes, sir.
Or that is not very important?
Actually, it's important. For example, there are other classifications with same other category, like carbamates with the same toxidromic picture, but treatment part in carbamates we can give atropine. There is no.
Suppose you are sure it is organophosphorus compound, but you do not know which compound it is. Would you like to know, or it is not necessary?
Actually, we should know. So because some like parathion, malathion, they will have delayed presentation is there, sir. Even if the patient will have symptoms only after 5 to 10 hours only. So that
What's
is one feature.
the mode of action of organophosphorus compounds?
One is there is rapid absorption, both inhalation, ingestion, or cutaneous or mucosal, following which its metabolism actually occurs in the liver. Actually, what happens is it inactivates the cholinesterase enzyme. As
By
a part
what
of
mechanism?
it's a covalent bond. It's a covalent bond formation. Actually, alkalization. I think alkalization of the
Phosphorylation.
phosphorylation.
And enzyme reactivators, like what are the reactivators that are used?
Pardon, sir, I didn't.
Enzyme reactivation. How do you accomplish?
Okay, and there is something known as what happens is that once the phosphorylated acetylcholinesterase compounds are formed, one possibility is that it can undergo spontaneous hydrolysis. Another possibility is that if you are getting pyrrolidoxine, this pyrrolidoxine will bind with the already inactivated or acetylcholinesterase enzyme, and it is actually a free radical donator, and it will reactivate the already inactivated acetylcholinesterase.
Put it in simple terms, it will dephosphorylate.
The patient.
So, is it important to know which kind of organophosphorus compound is? I'm coming back to the original question.
Yes, sir.
Because some compounds are resistant to dephosphorylation. Some are very easily, So, can you give approximately as to what kind of compounds are resistant to reactivation and what kind of compounds may in fact spontaneously reactivate? And if you give oximes, that is faster.
Sir, one is carbamates, they won't reverse.
No, carbamates are different entity.
Diethyl compounds are there.
Yes, I want to know about that. Diethyl and dimethyl. There's also now something called S-alkyl. But that's not all that important. Now, when you look at diethyl and dimethyl, what do you think? Which one is likely to be more manageable with oximes, and which is going to be a bit of a problem?
But I'm not so sure, sir. I think diethyl will be more easily reversed.
More difficult.
More difficult. Okay.
Dimethyl is
easily
more amenable to oximes. diethyl and S-alkyl are more resistant.
Okay, sir.
So they may not respond also.
May not respond.
Okay.
Okay, sir.
So that, of course, much of the time, finally, practically speaking, oximes over a period of time, if it is given early enough, will work. Anyway, that you will be coming to, I
Yes,
think.
sir.
Yes.
So that was the event that now she has been referred to Amrita, our hospital. So then I went to the systemic examination. I have already reassessed the entire systemic examination as in the primary survey. Then I already did an extra head-to-foot examination, sir. In head-to-foot examination, in oral airway, already we have secured the oral airway. Neck appears normal. Just the patient is having again persistent.
Documentation of pupil is very, very important.
Yes, sir.
In this, for medical legal purposes and examination purposes, that is very important.
Then still patient is having Krebs V's and heart rate S1 S2 was present. No visible burns or any scars. Nothing was present.
Fasciculations on the chest.
Chest
especially
muscle
in the-
fasciculation was not observed at that time, sir.
Okay.
Because already we have given her muscle relaxants.
Okay. No, maybe that.
Maybe because then abdomen was also per abdomen soft, not tender, but bowel sounds were increased for this patient, and pelvis and perineum were within normal limit, and muscular no other injuries, no visible bruises, nothing was there for this patient, sir. And so I came to the end with a provisional diagnosis that this case is a possible organophosphate poisoning with the possible complications that patient has developed an aspiration or patient has developed an seizures because of seizures and aspiration. Now with the CNS manifestation and all the opioid poison manifestations for this
One
patient.
more thing we have to suspect here is many patients take the
Co-injection.
alcohol
Injection.
co-injection.
So since
So
it's a
since the patient is since it's a
female
female, it's
patient,
okay. Otherwise, patient is having lactic acidosis, metabolic
Yes, sir.
acidosis, or this opioid poisoning. We have to always suspect and keep an eye on that. And if needed, we have to send investigation for that.
Was there any characteristic odor in this case?
Actually, I noticed some amount of kerosene odor, sir. Kerosene.
Is the intensity of odor linked to severity of poisoning?
That we cannot mention, sir, because from the patient might have spilled the poisoning to the clothes, everything. Maybe.
What is the odor due to? Is it organophosphorus compound?
That I'm not so sure, sir.
It is not. That is why it's not all that important.
Okay.
It is related to solvent which is used, which is a petroleum distillate.
Okay.
So the intensity of odor indicates increased in the presence of solvent, not necessarily OB compound.
Okay.
So don't go by, that there is a lot of, odor, so therefore it must be severe poisoning, not necessary.
For this patient, it was a mixture of vomitus was there. This one that already she was positive, so it was very difficult to identify. We have sent her a routine investigation along with the toxicological sample for the gastric vomitus. The vomitus they have brought, we have sent. Along with this, we have sent the pseudocholinesterase.
We have to send vomitus, urine, and blood. 3 things.
Yes.
We actually
You have
sent
done
all three
all.
we have sent. And then pseudocholinesterase, when she was admitted in ICU and in as emergency, we have also given atropine, sir. Atropine, we actually we are getting in ampule, sir. In one ampule, we are getting 0.6 mg. Ideally, so I guess.
One doubt, sir. One doubt is that whether we have to send everyday cholinesterase level on or only at the diagnosis.
I think we can send at presentation for baseline estimation, and after that a few hours later to find out whether it is decreasing or not.
We can do it.
Maybe once or twice you can repeat.
Okay.
Whether there is a tendency for progressive decrease or whether it's picking up or stabilizing.
Okay.
But at the time of presentation, very important to
Yeah,
know the
yes.
baseline, because there can be variations. Even if you go by the reference ranges that is given for pseudocholinesterase, may be different in different individuals.
Okay.
Sometimes some people have inherently low cholinesterase level as normal.
Okay.
So in order to find that out.
Decreasing trend, we have to move.
Yes, exactly. That's more important.
Okay, sir. And now I gave her. We are getting in 0.6 mg in one vial.
Yeah.
So actually, I gave initial of
One ampule is
0.6
and
mg.
vial is
Vial is
0.5.
1 point.
Sorry, vial is 1 mg.
1 mg.
Ampule is 0.6.
Yeah, we are getting ampules I had,
Okay.
so I gave her 1.2 mg, but initially we can give up to 2 mg,
Okay.
and I repeated the atropine every 15 minutes. So totally I had to give around 7.5 mg atropine, and I target endpoint I mentioned was when her respiration becomes clear. Sir.
Okay.
But to say that atropinization in theoretic in an OP poisoning case, the most important thing is that adequate chest secretion has gone. But other features we can see is that the patient's heart rate increased more than 80, BP increasing more than 80, and pupillary dilatations can be checked, sir.
Pupils may be the least important, because sometimes you have seen, I'm sure you also have seen,
even one
pupils remain constricted for a long time, even though the rest of the things have improved. So not very important. I want to ask you something else with regard to what you said just. What were the things that you did just now? You mentioned.
Sir, treatment part, sir.
Yes.
Treatment part, immediately we have secured her airway, and we have started her on IV fluids as an immediately.
No, you mentioned something about atropine. Atropine, how much did you give?
Actually, I gave around 7 to 7.5 mg, sir, from what I remember. Amount of atropine, it's very high dose actually I required. Maybe some amount of aspiration itself is causing that ongoria.
You start with how much atropine?
Actually started with 1.2 mg.
Okay.
Actually,
after that you wait for some time.
10 to 15 minutes.
10 to 15 minutes.
Then
you repeat the same dose.
Same dose. Actually, I increased the dose, sir. And I gave only 1.2 mg subsequently.
Because there are some reports saying that you can double the dose each time.
Yes, sir. Since he is already having tachycardia, everything, so I didn't go into higher.
Normally, two ways we give, sir. One is like intermittent dose, another one is an infusion protocol.
Okay.
Infusion protocol means that will be like it is a short acting drug. So when we give, we look at the heart rate and titrate the dose, but end point is always the secretion. But where the infusion facility is not available, we give it as a bolus dose also.
For a child, what would be the dose of atropine?
Sir, it's actually 0.02 mg per kg in atropine.
0.02 mg per kg.
Yes,
okay.
Maybe 10 kg child will have half an ampule requirement.
What I remember on WHO protocol is 60 to 75 microgram per kg. Maybe it works out to something like what you are saying.
Same, almost.
Yeah. That's how I remember. Okay. Yeah.
Then along with that, I gave her pralidoxime also. PAM was not given from outside, so initial boiling dose of 30 mg per kg was given. Actually, we are getting 500 mg dose available. So I calculated and gave 30 mg per kg bolus, and I started her on infusion also at 8 mg per kg per infusion. Atropine also I calculated the 20% of the initial bolus dose, the initial dose requirement, and I continued the 20% of initial dose with the per hour infusion of atropine also. So both atropine and pralidoxime infusion was continued.
And in carbamates, any difference in pralidoxime?
Actually, carbamates, pralidoxime has no role, sir. Pralidoxime does not reverse the
it is not necessary.
Reactivation is
carbamylation is different from phosphorylation. Carbamylation is easily reversible. Whereas phosphorylation you have to dephosphorylate.
But some papers shows that it may be harmful also.
It could be harmful. Yes.
But the problem is, sir, when we get a case, we may not be knowing whether it's a carbamate or a OP. So we'll be forced to give PAM initial hours.
Yes.
That is the only issue.
That is recommended, because though it can be harmful,
it may not be.
It is very rare.
Very
few reports of real harm due to oximes, even in carbamate.
So we can give.
So certainly, if you don't know the identity, you have to take it.
PAM also, while giving, you have to give only over 20 minutes because possibility of associated. Suddenly, if we give cardiac arrest, respiratory depression, everything, all complications, laryngospasm, everything can be possible complications.
Is there any other controversy regarding oxime administration? WHO recommendation is give both.
Okay, sir.
Are there any other studies saying that oximes, even in organophosphorus compounds, need not be given? Have you come across reports like that?
No, I'm not sure, sir.
Actually, there are reports from India itself, as well as countries like Sri Lanka, which say that oximes are actually neither useful nor beneficial in organophosphorus compound. Sometimes can lead to detrimental effects, and since there is no convincing proof it's going to help, why do we give oximes? There is a controversy. I'm not saying that you should follow that. We follow WHO protocol, and WHO still says combination of atropine with oximes. Now, how much maximum dose of oxime can you give? So you are using pralidoxime. What's the maximum dose, say 24-hour period for an adult? Recommended. Beyond which, not advisable.
I'm not sure, sir. Initial 3 and I know.
How much can you give per hour?
Per hour 8 mg per kg infusion is
8 mg per kg per hour.
Ah.
So suppose you extrapolate that in a 24-hour period, how much does it come to? That's what I just asked.
Then 24 mg per kg or I mean 24 and we'll have to calculate.
Generally speaking, WHS is 0.5 gram per hour to maximum 1 gram per hour. That's a absolute maximum. Usually it's point. So we give about 12 gram over 24 hours, and maximum is 24 grams. But usually 12 grams is sufficient. Now one more question before you wind up. Which will you stop first, atropine or oxime, when you are giving both?
We have to stop the atropine first, then we'll have to continue pyridoxine for next 12 hours, sir.
Okay.
Because inadequate PAM treatment can lead to intermediate syndromes.
There are controversies there, but doesn't matter. Yes, that's a protocol that is recommended. Yes. Okay, you can continue.
Can you tell about glycopyrrolate here?
Sir, glycopyrrolate is actually again an antimuscarinic agent. Thing is that atropine has atropine has a capacity to cross the blood-brain barrier. So possibility of developing an atropine psychosis is there, and atropine psychosis is like patient will have altered sensorium, agitation, everything will be there. So in such scenario, we can use an glycopyrrolate. It doesn't cross the blood-brain barrier. So we will have to use the glycopyrrolate. We are available. It is a 0.2 mg, but we can use the same dose of atropine with the glycopyrrolate, or we can actually start glycopyrrolate and atropine as a combination also.
So atropine alone can be given, glycopyrrolate alone can be given, combination can be given. Because the OP itself can produce neurological problems. In that condition, if atropine produces a neurological complication, you reduce the dose of atropine, mix co-administer atropine with glycopyrrolate, because so that atropine toxicity will come down, brain action will be by the atropine, and other action will be taken care by the glycopyrrolate. So it has to be used with caution. Okay, so we have less, like time is 30 minutes over, sir.
Okay.
So anything else we want to?
There were some other aspects.
We can discuss that also.
Yeah. Like for instance, atropine, when you say it's an antidote, does it take care of mainly muscarinic or nicotinic manifestations?
Actually, it takes care of mainly muscarinic activities, sir. Nicotinic.
So what part of the cholinergic syndrome it's not effective?
Nicotinic part, actually it's not so effective, sir.
Can you tell me the main manifestations that may be present will not be taken care of by atropine?
One is muscle fasciculation, muscle paralysis.
Why is that?
Actually, atropine is an anti-muscarinic blocker, sir.
Where are muscarinic receptors present?
Muscarinic receptors, multiple areas are there. One is in cardiovascular system is there, and another is that gastrointestinal tract in the pupils.
Are muscarinic receptors present in skeletal muscle?
More of nicotinic receptors are present in the neuromuscular junction, sir. That's why we don't get much of.
Muscarinic receptors are mostly present in smooth muscles. And glands. And of course CNS, it's always present as CVS. But nicotinic receptors are present mainly in skeletal muscle. That is why atropine cannot take care of muscle weakness, muscle problems, skeletal muscle problems, which will have to be taken care of by other means.
Yes, sir.
Intermediate syndrome is
intermediate syndrome is something that happens after 48 hours of poisoning, in which actually it is because of the delayed release of the organophosphate from the fat tissues, and also whenever we are not giving an adequate pyridoxine, patient will have presence like orbicularis muscle weakness followed by neck muscle weakness and proximal muscle weakness, finally can even lead to respiratory pressure. But what we can do right now is that we have to give atropine for this patient who are landing up in intermediate syndrome.
For completion's sake, you can tell something about delayed polyneuropathy.
Then delayed polyneuropathy is something that happens even after 3 to 4 weeks of an OP poison. In such scenario, the patient will have actually more of distal muscle weakness along with the sensory involvement, sir.
One of the most important finding in ICU may be foot drop.
Foot drops.
You have to look for that.
Distal muscle weakness. Along with sensory won't be there in the intermediate syndrome, but in delayed presentation, sensory, it is mainly because of demyelination.
What is recommended to be done periodically in a patient admitted with suspected OP poison to find out the possibility that he may be going into intermediate syndrome?
Pseudocholine esterase level can be checked, sir. If a very low level.
Clinically?
Electromyogram.
Which muscles are mainly affected in intermediate syndrome?
Intermediate syndrome, proximal muscles are
mainly?
Eye, neck muscles.
Neck flexors. So one of the things recommended is, you ask the patient to lift his head off the pillow. If he's conscious, and maintain it like that.
Okay.
If he is experiencing difficulty, it means he may be going into intermediate syndrome. That's a sign. That's
Some patients will develop
ominous sign.
hypoxia, sir, because of the diaphragmatic weakness. In that condition, we'll have to do EMG.
Okay, okay, yeah.
Otherwise, next flexion is the most important,
Yes.
like you told, in ICU.
Yeah. And any other enzyme is involved in the production of syndromes like this? Is there any other enzyme that is inhibited by organophosphorus compound, which is what is now said is responsible especially for delayed syndrome? Or is it only acetylcholinesterase?
I'm not.
There is something called neuropathy target esterase.
Okay.
And it is said that depression or inhibition of that enzyme is probably responsible for complications like intermediate and especially delayed syndrome.
Okay, sir.
Okay, sir. Thank you, sir.
Sure.
Thank you, Riyaz.
Thanks.